Salt Lake City at the University of Utah School of Medicine. I graduated and did a residency in family practice and community health. That was back before there was a School of Public Health here, and I got a master's in public health here. That graduate degree, the MSPH that I got, was a much more interesting, fun degree for me than my MD. Although I did enjoy very much being a family doc on the west side of town for a few years, most especially while I was still in training. I emphasized environmental health problems while I was in my master's degree. My first job out of training was at the Occupational Safety and Health Administration, U.S. Department of Labor in Washington, D.C. I was a medical officer. And then I became the state health officer for the state of Nevada. So I had a period of time where I led a state health agency. My next position was in Denver at the National Jewish Center, which is a tertiary/national referral center for lung diseases. And I took care of people with occupational and environmental lung problems like black lung, asbestosis, occupational asthma. Since then, and for a short while after that, I was with the Colorado Department of Public Health and Environment, and again, in a more traditional public health setting. Since then, I've been principally doing public health and environmental health consulting work. I still have a business, I guess. It's not a real practice because I have long since stopped actually clinically taking care of patients. But I try to help government agencies, businesses, variety of communities with environmental health questions like, is there a cancer cluster here? What kind of indoor air quality does our building have? Do we have illnesses that are related to some sort of environmental exposure? I do a lot of work for the workers' compensation courts here in Utah, adjudicating or helping them adjudicate claims that are in dispute between a variety of doctors. The defense doctor making a statement that there's no problem here, and the treating physician claiming that in fact the workplace is the cause. That's my background. As I've gone along, I've been in primary care settings as a family doc. I've been in academic medical centers, both as a family doc and a specialist. Been in a tertiary or regional or national referral center. Had that experience, and in a health department at the state and the federal level both. So as I've gone through all of those experiences, I've accumulated a lot of strong feelings, opinions, I hope somewhat based on fact. You can judge that for yourself as I show you what I've learned about our health system, which I find to be woefully inadequate. And so I'm going to give you, I think I'm on the agenda for this class because I have the radical point of view. So feel free to throw your darts and shoot your arrows. If you find this to be unacceptable, we need to talk about it. We haven't done a good job in the United States of actually having a conversation that's reasoned and logical and oriented to both the facts of the case and to our closely and dearly held values. So let's start that conversation because obviously things are changing. I've titled it Wasting Away, How Americans Do Healthcare Business and What Must Change. I don't really know what this thing means except that you can find some of the stuff I post online by going there. And there's my blog page. I've also got a Facebook page. I'm not of your generation, right? The first time I saw a website, and I was actually supposed to be managing a website at the Colorado Department of Health, I looked on the pages for about 15 minutes and got so dizzy I had to go outside. So be patient. One thing I need to, let's see if I get this right. It's right, okay. You probably hear from Dr. James, right? He's coming. Has he already been here?
No, he's coming.
Okay, he's coming. He's a well-known, internationally known quality of care specialist at IHC. And years ago, he gave me a bunch of his slides and gave me permission to use them. I wonder if he now wishes he hadn't. But when you see a slide that has a blue field at the top and a black field at the bottom, that will be one of the slides I borrowed from him, and I'd like to acknowledge that. Like this slide, just so we start off on a relatively positive note about American healthcare, there are some things we seem to do really, really well, and I think this is the reason why it's easy for our politicians to tell us all the time that we have the best healthcare system in the world. For instance, major trauma cases have a lower mortality rate in the United States than in other first world nations, as do patients with heart attack and neonates who are born very small and therefore likely to be very ill. All have better mortality rates in our country than in other countries. Nonetheless, if you take a little broader look at the quality of care, at least as it can be typified by mortality rates that are carefully controlled for a variety of factors, to see whether a health system in a given nation has an optimal impact on reducing mortality. These are mortality rates that are adjusted for a variety of things that have nothing to do with healthcare, like very aged people when they die, say in their 90s. Healthcare really can't do much about people dying in their 90s. So this is deaths before age 75, and they chose a variety of kinds of causes of death that would be proper healthcare interventions. When you use that, this study's been done a couple of times, once in 97, 98, which are the white bars, and again, not quite a decade later, which are the red bars. You can see that worldwide, at least in the first world, I wouldn't argue that that's probably true anywhere else in the world, but in the first world, this is getting better. Even in the United States, which is way over here, out here, it got better from the late 20th century to the early 21st century. But we were not the worst in that first study, but we are the worst in terms of that rate now, or at least in this most recent study, because we improved less well than the rest of the world did on this matter. So, given that we do have some good things about our healthcare system, if you look at an overall measure like this, we lag behind the rest of the first world. Not such a good thing. A lot of people have argued that the reason for that is that a lot of Americans don't have health insurance. They're not covered. Coverage has always been the big thing that people talk about. This is an article published 6 or 7 years ago about mortality rates associated with uninsurance. If you're not insured, usually it's for a period of time because you were employed and had insurance for a while, either moved off that job and lost that insurance, or for whatever reason you're on the insurance policy because your parent had it and that there was a job change. There was a period of time when you weren't covered. So this group of authors weren't trying to look at just the people who were currently uninsured, but the people who had had uninsurance experience over a period of time and tried to factor in a variety of things about whether that had an effect on mortality rate. And they came up arguing that, in fact, excess deaths could be numbered, and they said in the total U.S. that year, and this is a 2009 study, there were about 45,000 deaths that were attributable to principally the fact that the family lost its insurance for a period of time, therefore the care for the hypertension or the diabetes or whatever went out of control. They didn't have as much access, and therefore there was a death related to what should have been something that the health system could have cared for. Well, this is commonly driving American health policy discussions. Here's a slide that I don't know how many times in different ways you see this portrayed. The mountain that American lack of coverage becomes over time. This mountain, this portrayal of it ends just before the passage of the Affordable Care Act. And of course that would have been associated with a drop in the peak of the mountain for a period of time, but not down to zero. In fact, it dropped to about this level right here, which would have been somewhere around the level when Bill Clinton was elected president. None of you were probably voting back then, right? Some of you. Okay, so, I mean, this doesn't probably make sense to you, but Bill Clinton ran on doing health system reform. You probably by now have heard, based on his wife's campaign last year, that she was an integral part of his attempt to do that, and they were arguing that it needed to be done because there were 30 million uninsured Americans, and that was an awful, horrible, terrible thing. I'm not arguing with that. I do think it's a really ridiculous thing that in the United States we have people who don't have financing for health care. But this has driven the health policy discussions. And so we got another coverage initiative out of Congress. When President Obama was elected 9 years ago, he had neighborhood meetings all around the country. I went to the one that was here in Salt Lake, or one of the ones, where we could talk about and share what we thought would be the proper things for health system reform. It was all about coverage. And that's what the bill ended up being about. You were mandated to buy it, which mandate passed the Supreme Court review. If you weren't wealthy enough to even be considered for the supplements that were going to be paid for people to buy the insurance, then you could possibly be a beneficiary of the expansion of the public programs, most especially Medicaid, which was going to go up to 133% of the federal poverty limit. You were going to be able to buy these in new ways, this exchange idea, which is still working. And private insurers were going to be, in order, sort of the trade-off, they were getting a whole bunch, millions, tens of millions of new customers, and as a trade-off, they were having to give up some of the things that they love. For instance, they love